please simply the video feed. And now it's a great pleasure to introduce our speakers. Our topic today is a somber one, but important to think about. Medical assistance in dying is, for some people, a welcome component of end-of-life care. So I wish to introduce Carmen Hobbs, RN, who has been with the MAiD program since 2018. Her nursing experience is broad and includes work in intensive care units, addiction services, inner city wellness, and palliative care. So thank you for being here. We look forward to your talk. And I must say, it's a special pleasure to have Dr. Paul Humphrey here, an unexpected pleasure. And Carmen will make any necessary introductions to Paul.
Perfect.
You're on.
So thank you so much. Can everyone hear me okay? I'm a little farther back from the, okay, perfect. So I've asked Dr. Paul Humphreys to join me. He's part of our care coordination team. He's been a family physician for over 47 years in Alberta, and he's had a background in anesthesia, palliative care, obstetrics, and medical teaching. He's been the community lead physician for the North Sector since its inception in 2016. His current clinical focus is home palliative care, although he's stepping away from that a little bit and mostly focusing with his role with us. He was a founding director of the Northwestern Ontario Family Medicine Residency prior to his recruitment to Edmonton in 1998. And he's been a president of the Alberta College of Family Physicians, director of family medicine residency programs, vice chair of CARMS, and a member of the CFPC board and committee on accreditation. So we're very thankful that Dr. Humphreys could join us today. So I'd like to just go over just a bit of a review of what MAiD is, what is our role, how does a patient's journey look when they're applying for MAiD, and specific learnings that we found within Alberta. But certainly I'd like to leave lots of time at the end to open it up for questions. So let's leave lots of time at the end for some good discussion. So what is MAiD? The criminal code defines it as the administration of a substance by a physician or nurse practitioner that will cause the death of the patient. So there can be sometimes some confusion with MAiD with other terms that you might hear around palliative care, like palliative sedation. But it really is a federal right that we have specific legal criteria that we follow, and ultimately is the administration of medications to actively end someone's life. And what is our program? So I'm what we call a navigator program. So I have a few colleagues and we cover Edmonton and Northern Alberta. And our role is to act as a single point of contact for folks. So referrals often come from patients themselves, but we also receive referrals from family, from facilities, from other healthcare providers. So we act as that single point of contact. We do a general intake for those folks, and we make sure that we're connected, that folks, our patients are connected to other supports like SAGE or like home care supports, sometimes even as simple as finding them a family physician, anything that they might need to make sure they're well resourced, because we want to make sure that MAiD really is the last option that they end up choosing. We are not involved in determining if someone is eligible for MAiD, but we do arrange their assessments with a team of physicians and nurse practitioners that we have. I won't bore you too much with the legal background, but I would like to note that MAiD has been a legal right in Canada since 2016. Some of the legal criteria around how someone may be found eligible changed in 2021. So everything that we'll review today is going to be current legislation and current eligibility. So what makes someone eligible for MAiD? You must be at least 18 years of age or older, and you must be eligible for healthcare services funded in Canada. This basically just eliminates any medical tourism so that folks don't come to Canada just to receive MAiD. It must be a voluntary request, and you must have been given informed consent, meaning you need to know all options to relieve your suffering outside of MAiD. And this request cannot come from anyone else but the patient. And certainly, as I mentioned, the request can be facilitated, especially if a patient is weak or in pain. They might need help making this request, but during the assessments, they will ensure that the request is directly from the patient. And lastly, they must have a grievous and irremediable medical condition. So that must be a physical condition. And actually, I'll have to excuse you, my PowerPoint is a little not up to date. The mental health criteria, which we will touch on, has been postponed until 2027. So what does grievous and irremediable really mean? It's a serious and incurable disease. You must be in an advanced state of irreversible decline, and you must be having suffering that is intolerable to you, whether that's physical or psychological. And so basically, you know, it's really that incurable piece. This is not a reversible disease, illness, or disability. And you must be in that advanced state of decline, meaning even though you might have had a diagnosis that is life-limiting in nature, your functional status and your ability to engage in acts of daily living are likely going to be very difficult as well. So with those legal changes I mentioned from 2021, we now have a two-track approach to MAiD. So if someone meets all the eligibility criteria I just mentioned, the physician or nurse practitioner will then put them on a track. So track one is the same track that has been legal since 2016, where they have a natural death that we call reasonably foreseeable. Now, that I know sounds a bit vague, but basically if they are on a trajectory towards death, or, you know, a best example for those cases would be like a metastatic cancer, we can fairly easily prognosticate those folks. And if we're expecting their natural death to be in the next few months, they will be put on our track one pathway. Those folks have no waiting period. There used to be a 10-day waiting period, so that still comes up, but there is no longer a waiting period. At the same time, we do try and reinforce that MAiD isn't an urgent service, so we still need to make sure we're following that legal framework and protecting not only patients, but also assessors. Track two is for folks who meet criteria but do not have a natural death that's reasonably foreseeable. So those folks, an example there might be someone with chronic pain, or even some MS or Parkinson's patients who are still meeting that criteria but are a little earlier in the trajectory of their disease. Those folks have a 90-day waiting period that starts the day after their first assessment. So what are some safeguards that we have in place? So all requests for MAiD, whether it's just a request for information, we will certainly still do intakes, but we will not start assessments until we receive the record of request, which is a written form that we provide to patients or can be accessed on the Alberta Health Services website. And it just makes the request official so that we have it in writing that someone is requesting MAiD. The patient's eligibility for MAiD is determined by 2 assessments. So again, that's something we arrange. And certainly the assessors go to the person's home or wherever they may be residing, whether that's in hospital or facility living. We would never expect a patient to go out to receive that assessment, especially if you can think about someone at end of life or who's really suffering. That would be really difficult. For the first assessment, we do sometimes engage someone already involved in their circle of care, whether that's a family physician, an oncologist, or a specialist, but not all physicians or nurse practitioners are comfortable being involved, so there's never any obligation. So as I mentioned, we do have a team of physicians and nurse practitioners that we will assign to cases, and they will make appointments with patients. Again, that informed consent, that is also a requirement the day the patient receives MAiD. They must have capacity the day they receive MAiD, and must be able to provide consent, whether written or verbal. And lastly, of course, there is never any obligation to ever move forward with MAiD, and so the patient must be aware that they can withdraw or pause at any point in the process. Additionally, for our track 2 patients who do not have a natural death that's reasonably foreseeable, they must have seen a specialist or someone who considers themselves an expert in their condition to ensure they have been able to explore all options to relieve suffering. So again, going back to the chronic pain example, they must have seen someone who specializes in chronic pain to ensure they've adequately explored options to relieve suffering before MAiD will be an option. And again, the 90-day waiting period as well. So very quickly, what does a journey look like? A patient or family connects with us, or a referral comes in from a healthcare provider and we connect with that patient. We guide them on how to fill out a record of request and ensure they're connected to services that may be appropriate. We arrange for their first and second assessments for eligibility. And then this is the other piece, and not all of these pieces are necessarily required, but if the patient decides to go ahead right away, we help make sure their advanced care planning is in order, that they understand and the family understand what happens after death. We confirm where they are having MAiD is appropriate. So most folks have MAiD at home, but certainly if they're in hospital or in a facility living, we just confirm with the site to ensure that MAiD can occur on site, because MAiD typically is not allowed on faith-based facility sites. So if that's the case, we would arrange transport for an alternate facility, and we also ensure that IV access is not going to be an issue on that day. So on the day of MAiD, as I mentioned, the patient must have capacity. If they do not have capacity, we cannot move forward. The only option in that scenario is if we have something that is also new as of 2021, which is a waiver of final consent. It's applicable to our track 1 patients only, so they must have a palliative diagnosis and be considered reasonably foreseeable with their natural death. If they sign a waiver of final consent directly with the person who is going to provide them with MAiD, they may still receive MAiD on the day of their choosing, even if they have lost capacity. So just to give you a quick example to make sure that's clear, if I was approved for track 1 and I thought I would have MAiD on April 30th, and Dr. Humphreys is my provider, him and I could sign this waiver of final consent that says if I lose capacity, I would still like MAiD on April 30th. And that way on April 30th, or even before, if I lose capacity, my family can call the MAiD program, let them know I've lost capacity, but they knew it was my wish for me to have MAiD, and we could still move forward with that request. After April 30th, that form expires. So there's no obligation for me to have MAiD on April 30th, but we would have to sign a new one when I was ready to set a date if that was still appropriate. Otherwise, we would move forward with informed consent like we normally would. The providing practitioner would receive the medications from a supportive pharmacy, and there's a direct handover of medications. So that's another safeguard as well, that the medications are looked over by a pharmacist and given directly to the providing practitioner who is responsible. An IV is started. We have a nurse who attends all events. So they start the IV, they witness the consent form and support the family as needed. And if the patient says they're ready to move forward, the medications are administered by that provider. After death, our practitioners pronounce death, but all MAiD death certificates are signed by the medical examiner's office. The body does not go to the medical examiner's office. It just is treated like an expected death. So they go directly to the funeral home, who will pick up from wherever the MAiD event happened. But the medical examiner signs the death certificate and gets it directly to the funeral home. And just a few statistics so that you can see how prevalent MAiD is. So that middle number there, almost 4,000. We might actually probably be at 4,000 by now, because this was as of the end of 2023. So we'll say about 4,000 MAiD provisions within Alberta total. In Edmonton, in the top left corner, we've now had over 1,350. And as you can see there, actually most do happen in facility. You know, we certainly would follow someone into hospice, and that would be considered a facility event. So And in the bottom left, you can see our numbers are growing quite a bit. Certainly, we don't advertise, but we're finding more folks, you know, more and more folks know someone who has had a friend or a family member go through MAiD, and it's becoming a little bit more of a well-known option within, you know, other palliative care resources. We most often see cancer patients, but we do also see some neurodegenerative disorders like ALS or advanced lung disease, COPDs, those types of disorders. I won't stop too much on this, but one question that often comes up is what happens with someone who has dementia? And that, I would argue, is one of our most difficult disease processes to work with, because, to be completely honest, the legislation doesn't adequately cover someone who has dementia, in my personal opinion. Dementia certainly has qualified. Folks who have dementia can qualify for MAiD if they meet all criteria, but they still must be of sound mind. And most often, folks with dementia fall under our Track 2 pathway. So that waiver of final consent is not an option for them. Certainly, we look at a patient as a whole. So that's not to say that someone with dementia wouldn't qualify for Track 1 if they had other health conditions, their age, we look at their functional status, but most often they're found for eligible for Track 2. And if they lose capacity, if they wait too long, again, they wouldn't be able to have MAiD. So the dilemma comes in where you have to choose to have MAiD earlier than you might wish, because you're worried about losing capacity, and that determination can ultimately only be made by the patient, and we respect their decision, whatever that is, whether they decide to move forward or not. Additionally, so mental health, as I mentioned, we were expecting the legislation to come through for this year. And actually just last week it was to be released, but there was a special report that basically recommended Canada's not ready to move forward with this request, that there needs to be a little bit more work and to ensure we have proper safeguards to protect patients and practitioners for a mental health condition to be eligible for MAiD. So that's been postponed until 2027. Again, not to say if someone who has a mental health disorder is automatically precluded from accessing MAiD. It just can't be the sole underlying medical condition or the primary driver for accessing MAiD. And that's basically the end of our presentation. And sorry, Dr. Humphries, I just took right over. Do you have anything to add?
I usually have more to do than that. I like doing the questions.
Yeah.
I just would make one comment. Could you clarify what the denominators are of those figures?
Yes,
I believe one was yearly and somewhere that question.
this one here.
Yes, that one.
Um,
It's two things. The one, some of them are Edmonton and North.
yes, and sorry, we separate those because we do consider Edmonton and North two different zones. So Edmonton would include all suburban areas, and the Edmonton zone actually does extend fairly far out west. So it does include some of Parkland County, but northern Alberta would be anywhere basically north of, I think towards the east, anything north of St. Paul. We do cover as far as Jasper. And then north of Edmonton, I think Edmonton turns into north in Sturgeon County.
Yeah, basically the hill.
Yeah.
Yeah, but the other one is the Edmonton figures are the total for 8 years.
Yes, that's right. So 150 total over or since the inception of MAiD in 2016.
Yeah, and then the ones that are dated are just for that particular year. So there's two different denominators there.
Yeah, exactly. So the bottom left would be per year, just to demonstrate growth, and that would be all of Alberta in those.
All of Alberta does. It's many people are curious, how significant is this in death in Alberta? It's around 2%. One of the last calculated ones was 1.85 or some such thing. We had estimated when we started planning, which I was in on the late stage of planning before MAiD was made legal. They estimate by checking out other countries and a couple of other jurisdictions in North America that already had MAiD for it, they were talking numbers between 2.5% and 4% of the number of deaths per year. So we've been pretty conservative on ours. I think that's a reflection on who we have on the team that are very careful.
If you look at it, almost has doubled since 2021 to 23, though, is it projecting that obviously will be closer to that percentage at some point?
Well, the one thing that confounded it was as far as percentage goes and the confusions with healthcare through COVID made a big difference to what was going on. I would anticipate watching around the world, some are hanging around 4%, some countries or jurisdictions, and one or two are in the same range that we are.
Presumably there are data from countries that have had a longer experience, and you can see the slope.
Yeah, the Netherlands particularly is one that's a good marker because their culture is somewhat similar to ours.
How does Alberta compare to other provinces in the provision of base?
Well, frankly, I've worked in southern provinces as well. I worked in Ontario and Southern Ontario for 22 years before I came here. And I watched their program, and I watched Quebec's program, and I watched BC's program. I don't know a lot about the eastern provinces because they're not smart about is the point. But we certainly are more organized in a way that I'm pleased with. That's that we try to keep the events individual, personal events. We're not doing it with a team that goes out and we have a standard team that we send to this district and that district. We don't have that. We have resources that we pick up that are constantly shifting among the physicians and the nurse practitioners. And most of our team, core team, do not assess or provide. Now, we do have one other director, one other lead of the team that is providing. But there are people that we see all the time, obviously, that have gravitated towards doing this kind of work because they do it well and can tolerate the stresses of it. That worries us sometimes.
Sort of reminds us, in a sense of being analogous to transplant and the donor and anyone involved with the care of the donor is not involved in making transplant decisions.
Yeah, well,
It's not exactly analogous, but
the option is there. Like I certainly could. I haven't had a anesthetic experience in the background. I had all the stresses right when I was starting into practice as an anesthetist and a family doctor of the abortion issues. The big difference and it was very difficult to conquer in my sense because I was also building my family at that time. But I've always been a respecter of the autonomy of people. That an individual should make their own decisions about their own body. And that's our basic principle is that's where we start. I find handling MAiD is a less of a stress on me for my values because the patient is the only person involved. I found with abortion, you had one patient that really wasn't speaking, obviously. So that difficulty is not there with this. But it's very difficult to understand that because we do have family members sometimes come to us on the side or come to us officially trying to register for MAiD for their family member. And that's an absolute no in the legalities of it. And those conditions that were up there are reinforced as criminal code. I think the basic start for an offense and then was about 14 years of prison. You don't play it right.
perhaps open the floor to discussions, and I will start with the people online. Does anyone have a question online? Maybe raise your hand, Jan.
Hi, I'm wondering if we're finished with the slide presentation because it's hard to see anything. If we're not, that's okay. My question is, are there any volunteer opportunities to work with this program?
Oh, yeah, I can take this one, absolutely. So there is volunteers that we access through the Dying with Dignity organization. So the record of request form that I mentioned, the signature of the patient on that form must be witnessed by someone who's not family and who wouldn't benefit from their will. So for folks who are isolated, who don't have supports at home, or especially if they're admitted to a faith-based hospital or facility, the staff of those facilities can't help us, as opposed to, say, the Royal Alex or the university. We can ask unit managers or staff there to help them with that form. So there certainly comes times where folks just don't have anyone to sign as witness for them. And in those cases, we use volunteers with the Dying with Dignity organization. So that would be my suggestion for a good place to start.
Thank you.
Could I ask about a situation, maybe it rarely happens, where the two assessors disagree? Do they make an effort to come to a single conclusion, or do you leave? How do you handle that situation, and does it arise?
It happens more often than you might think. But I wouldn't say it's necessarily common, but especially with the legal changes in 2021, there has been differences in interpretations of the natural death being reasonably foreseeable. So most often I would say it's not a difference of opinion whether someone's eligible or not. It's a difference of whether they're eligible for track 1 or track 2. But certainly that can make a difference for a patient who's interested in a waiver of final consent, or if they are not willing or hoping to not have to wait the 90 days, that can impact them. So our steps would be to have those two assessors speak, and hopefully, once they've been able to talk about the case together, they can come to a mutual decision. But if no mutual decision can be made, we will follow the track 2 criteria, because ultimately the patient is still approved, but it's the safer pathway to follow. If they were found ineligible by someone and the other assessor found them eligible, we would still ask them to talk, hoping they can come to an agreement. But if no agreement can be made, we would offer a third assessment to act as tiebreaker.
I don't think we've ever gone beyond 3.
No.
I'm sorry.
3 has been the limit for
Yes,
us. We
yeah.
just a tiebreaker. So there was a lot of.
I've heard about a federal petition going around that people can put in their will and their healthcare planning that a MAiD is something that they want should they become should they lose capacity in the future. And I'm wondering if you've heard anything about that, or how that would change the process.
We hear a lot about that. It's I had that MAiD discussion with my family, 3 generations of people. The opinions on that issue in particular were the most argumentative of why not. No, it's I think that's the ultimate of individuality that you have to be able to say at the time. I would say that one of my children, adult children, had the best answer to that, being among the very few in the family that said they never would ask for MAiD. She said, I wouldn't want it in my will because I don't know how I'd feel approaching death and unable to make the decision then. So that hung with me to understand why that's an important issue, that it can't be written into something that I write today. My goodness, I wrote my first will when I was 19 years old.
Yeah.
And I wouldn't want that hanging around what my decisions were then, because my life and experiences and responsibilities have changed so much since then. But the closest we come is that agreement once you're authorized to have something that would qualify you. That if you lose capacity, then the second authorization isn't necessary. As a member of the team and as an individual that's had wide palliative experiences and a lot of medicine treated. I'm very glad that we do have that kind of restriction. It's a really handling a will, which I tend to be involved with the handling of the wills of many of my family members, because I've lived almost all of them. And it's very difficult to settle what's said in the will when it doesn't hang right with what you think the person would have thought.
Thank you.
So it's not, that option isn't available.
Yeah.
I doubt if it will be in any near future.
Thank you.
Any questions from the Zoom?
Go ahead, Joan.
Yeah.
Do you think that the decision to include mental health will be included in March 27, or do you think it's just gonna be pushed back again? Do you have any thoughts on that? Anybody?
History would say that it probably will go on as an argument. I think there's but remember, or not remember, I'm reminded by discussions I've had from the psychiatrists involved with both sides of that issue. That and definition and treatment of mental illness is very vague compared with everything else. Just do you have this disease or not depends on, most often, a set of criteria that are just count up 4 of these 5 things and this is the disease you have. That's that sort of thing. And also the developments in treatment. I mean, I don't think it's only MAiD that made a difference, but I've been doing palliative care exclusively for the last 9, 10, 12 years now. And I took that on because I thought there was more need for it in the community than for anything else that I was doing about my very highly variety practice. But the concern I've always had with my palliative patients is it worried me that I was just casually collecting the comments that I would hear from them, on that issue, and I was estimating that over 50% of my palliative patients would ask me at one time or another, "Can't you just kill me, Doc?" When they get frustrated with things and that sort of thing. And then when MAiD became available, I've only had 3 patients out of hundreds in the last 8 years since MAiD came in that have applied for MAiD, and only 2 of them, only one of them has completed it. One of them died before the event happened, and the other one said, "Hey, this isn't really for me," and took the exit route. So that statistic worries me when I think of how my patients were seeing life before MAiD was available and now. And one of my daughters that's been involved in healthcare has said to me, "Dad, don't fuss over that, for goodness sakes. You know, people like to know there's somewhere to go when everything else fails." And MAiD seems to have provided that. Before MAiD, it was palliative sedation, which is not a deadly thing to do, but it certainly does, in many cases, hasten death.
Yeah.
Joan, I'll just add to your point. I think another item that is important to recognize with mental health is ensuring that the disease is incurable and that symptoms are intractable. And as Dr. Humphries mentioned, that is so much more challenging with a mental health patient. And I think a lot of folks who would apply for MAiD would in fact not be eligible. Because ensuring that and ensuring they've had access to resources, long-standing psychiatric support would be a baseline minimum for us to really consider the request. So certainly, I understand fears in the community about folks with a mental health disorder accessing MAiD, but those acutely suicidal patients that I think a lot of folks envision accessing MAiD, those folks would not be found eligible. We would be connecting them with crisis resources. It's those folks who have insight, who have had long-standing suffering. And certainly the approach would be very slow and careful to protect all folks involved. Whether the government will support it, I also think it really depends on which government we have at that time.
Right. Well, I hope it gets simpler. I keep saying to all my healthcare people, and every time I go in for a checkup, or to my family members, like, I want MAiD. Like, I'm telling you right now, I don't want to linger if things are not going well. And I think it should be so much simpler. Like, why can't you just request it just because you're old? Like, and you're not having much fun anymore. Like, it just seems like it should be simpler.
Well, and on that point, like, often folks who, we have had requests from folks, let's say in their 90s, who have seen all their friends come and go and don't do much, and sometimes we even find they are ultimately eligible for track 2. Often, if you get into your 90s, you might have something, whether that's a heart condition, chronic kidney disease, even if your functional status is considered to the point to be a disability, right? It's not just disease, it's illness, disease, disability. So that's why we really do look at folks as a whole. We include their age, we include their functional status. So there's never any harm in applying if someone's ready for MAiD. We would like to support folks as best we can, and sometimes an application for MAiD, even if found ineligible, helps providers and other healthcare, folks involved in that care know really where that person's at. And maybe they didn't realize that things were not going as well as they thought, and they can hopefully increase supports for that person.
Thanks.
I have a question about faith-based objections to MAiD, and not the views of particular churches, but the individual who may be caught in a conflict between his or her faith and MAiD. How do you handle that situation?
That's a great question. I think from a navigation standpoint, we really just try, we are not the experts. We're the wearers of all hats. So I don't consider myself to be religious. I consider myself to be spiritual. So I am happy to engage in conversations with folks, but ultimately I want them to be able to connect with someone who can support them from a really knowledgeable standpoint. So if they're admitted into hospital, there's often spiritual care services that we can access, or even sometimes they bring in their own religious providers from the community. But often it's just, sometimes I think when folks are torn, they're really just not ready, and they need a bit more time to think about what they want.
Grant, did you have a question? And then Jamie.
Well, not really, just a comment. If it's a conflict of wanting and the religion saying no, it's still up to the individual. And until the individual can resolve that kind of inner conflict, it's not going to happen. So I really don't see that it's, as far as the state is concerned, it's not an issue. It is an issue as far as the person is concerned.
Grant, I had a very good example of that. I had a patient who definitely was on the path to be eligible for MAiD. But his family was pressuring heavily not to have him have MAiD. And we're doing things like flying him to California and to Arizona and whatnot for treatments, for which he got worse each time he went. Eventually, he came to what you're suggesting, said, this is my decision. And he asked for MAiD. And he was the one patient of mine that actually has had MAiD.
Yeah. Yeah, it's too bad that the state can't provide some mechanism to keep families from exercising that kind of, exerting that kind of pressure.
I think it's up to us to individually work with the patients to do it because there's no way to manage it through the state. I think we get a lot of objections of the interference with individuality from their side. But
Yeah.
no, that is a problem. We've identified a very common problem.
Jamie, did you?
Yes, so if somebody is found ineligible for MAiD, does that mean that they are permanently ineligible, or can they reapply at a later date? Should they choose to?
That's a great question, and absolutely they can reapply. But typically, if they're found ineligible, it depends on why they're ineligible. I guess I should preface this. So, if they're found ineligible due to capacity or due to, if they have a personal directive that's been enacted, for example, a personal directive that's been enacted, a medical professional has said this person does not have capacity permanently. So it would be very difficult for that person to reapply. They'd have to basically go through a reversal of that personal directive if they did have capacity. And certainly we know that personal directives have been enacted inappropriately, whether for good reason or not. So there are processes they might need to take. But a person could reapply if found ineligible if their clinical condition has changed.
Fair, thank you.
Any questions from anyone who hasn't had a chance to speak?
I was just curious, like, all costs are covered in this, like, even if you had to be transported from a faith-based facility somewhere else, or like, all costs are covered?
Absolutely, and in fact, the transfer is something we would never consider putting on someone because it's often not their choice that they've ended up at a faith-based hospital. If you go into hospital, you don't get to tell them that, oh, I'd like to go to the Allen, please, or we have a really good relationship with the Grey Nuns, but they are the home of the tertiary palliative care unit. So many of our patients have ended up in the palliative care unit at the Grey Nuns, so certainly, absolutely, that's all covered, including medications.
And MAiD happens in a medical hospital. Does the hospital have a say if it can happen?
Sort of.
Ethics again.
Yeah, exactly. So we really try and respect that, when we are working with a patient on site, whether it's a hospital or a facility, especially if it's private, ultimately they do have a say on what happens. But if it was an Alberta Health Services facility, there really should be no reason they wouldn't allow that patient on site. And typically, we have a lot of really good support from facilities, but if it's faith-based or a covenant facility, we'll be transferring them off site.
Yes, Jim, the point is, the institutions have been granted the right to say yes or no to whether it takes place on their property.
Yeah.
But they don't have the right to interfere with a person's request. And we have had a few squabbles at the individual level about that. Because the person. Yes.
Can I ask to go back to the issue with specifically of dementia? Is what I was thinking of. I mean, this has been a very useful discussion and a splendid presentation. I thank you. Do you reach out to groups like the Alzheimer's Society and the various others to begin to educate people about what they may want down the line?
We don't get a lot of voluntary requests like that,
Yeah.
but when I think about that maybe isn't true. Over the 8 years, I've spoken to many groups all around Alberta.
Yeah.
Very, very often they are those groups, even some of the religious groups. One of the diocesan groups for one of the churches asked me to speak at one of their dinners, and I felt kind of isolated since it was my church. But it is, part of our job as a team is to educate as well. And in my work with the university and administrative work that I do for AHS and whatnot, I get the opportunity to go into individual clinics and towns to help with education. And education in general, to me, also includes bringing up the topic of pain. But we're very open to any group that says, can you come and talk to us about this? Like, that's why we're here.
Yes, well, we thank you, thank you for that, certainly. We've got, well, we changed our screen. Are there other questions from the Zoom audience or questions from the floor? Hearing none, I'm gonna ask one other question. You said the majority of patients undergoing MAiD are patients with malignancy, advanced malignancy. The disease, I'll share my personal fear, the diseases that really would bring me looking for MAiD are the chronic neurological diseases, the motor neuron diseases and things like that. And I wonder, here, I would think that a small or a minority of patients with cancer end up with MAiD, palliative sedation, perhaps. It would be much more usual. With the patients with chronic neurologic disease with a predictable course, does a larger percentage of that group seek MAiD, or do you have those data?
I mean, I guess it's the prevalence as well in the community, right? So
One is much more prevalent than the
yeah,
other.
exactly. So, do you have any thoughts there?
Well, it's very hard to gauge.
Yeah.
You know, what the denominator of that would be.
Yes,
Okay.
yeah, that's the
But
problem.
but we do, the second compass thing that we have is the neurological. We get requests from people with ALS, some late stage MS even. Parkinson's as well, you know. I think we could go through, I follow that kind of thing because I have lots of those kind of patients in my practices over the years. And it's interesting that it is, as Carmen is saying, it depends on the incidents in the communities you're working in, how many show up.
Yeah, no, it does. Hi.
This is Peter. He's new to the group and hi Peter. Sorry.
There's another Peter?
Oh, no.
Pete,
Oh,
Pete.
Jim. Oh, sorry, Jim.
Sorry.
And we're just about finished, Peter, but please do join us.
Oh, sorry.
No, you
No,
should
no,
interrupt.
no.
Come on in.
No, we're just in a question and answer period. Do sit down and
The other comment I'll make while Peter's getting settled is, I think we're also, because we're such a small team, and we rely so heavily on specialists and folks that are working with patients that, you know, I think the Cross Cancer Institute and even the ALS clinic, as an example, or the movement disorders clinic, they have worked with our team now for many years, so they're a little bit more comfortable referring patients. They've done that referral process before, or even just initiating that discussion as an option. I think it can be difficult for practitioners to sometimes broach MAiD because for some folks it's really the opposite of what they would want, and you certainly don't want to alienate that person or impact that relationship. So you know, the ALS clinic, that's just an example, is absolute experts in palliation. So you know, they make sure that and we are very comfortable when an ALS patient that we're working with is involved there because we know they're going to be adequately covered with other options that might be available. So it's not
to have all of the options discussed early on, it seems to me a reasonable approach, that rather than waiting till it looks imminent.
And so all practitioners have the same level of autonomy as they would as citizens. And so I have many colleagues who do palliative care and would never be involved with me because of either their religious background or their personal choices. On the other hand, the standards for medicine, and I assume for nursing, is to be open about it to your patients and offer it when appropriate. To me, doing palliative patients, that's in the second or third conversation I have with any new patient. I bring it up, and if they ask about it sooner, go ahead and explain it. But I'm certainly not a salesperson for MAiD or any.
No, that would not be.
Yeah.
But has there ever been a time that it might seem like physician doesn't seem to suggest it because it is against their?
Oh, yes. Yeah, and there's every right to do that, but they must make sure that somewhere the patient who might have a need for it has that information, and that's the difficult one.
Let's say, how do you ensure that's happening?
Are they referring?
I'm sorry?
Can they refer that?
Yes, I can refer to our team or to one of us that does help.
We did have an example a few years ago of a pathologist who left his proper territory and became very much a salesman. I think I've forgotten his name. I've repressed it. I think he's a pathologist.
Do you mean North America wide?
Yeah, in the US.
Yes. I've forgotten his name too to begin with. I can't. Yes, and we're trying to avoid that as a
Yes,
team.
very.
We do not want
that
a
was
MAiD
great.
clinic developing.
Yep.
And we do not want a MAiD objection group starting to be active to the point of interfering with individual choice. You know, you can certainly, anybody can express their opinion, but to be in a position of authority and block people from MAiD would be like blocking them from pain control or.
This, in other fronts, is an issue that this group knows particularly well.
We also always try and ensure that any type of practitioner does refer, even if they don't think the patient is eligible. And more often than not, the practitioner just isn't aware of the expanded legislation for the non-reasonably foreseeable death, which of course expands our reach for MAiD. So we really also try and reinforce, refer them anyways, because at the very minimum, even if they aren't eligible, we'll connect them with resources. But if they aren't aware of the current legislation, then that you might be prohibiting someone's access to MAiD who might be eligible.
Well, I have the sort of feeling that I think many of us do, that death will happen, but I'm immortal. Somehow I'll be excluded from it. But there's something comforting to know that if I'm wrong in that position, there are all these options up to and including MAiD. So I can see how it's frightening, but I also think there's a comfort level in that that's important. Peter, you came in at the end of our discussion, as you gathered. I don't know whether you had any questions specifically about our topic today, or whether you were even aware of what the topic was. It was MAiD.
Where the
Yeah.
topic, professor of mine on Salt Spring Island is one of the earlier founding members of the Right to Die society, and I think in the end it was probably a home care worker. That maybe I forget, but yeah, he knew when he was going to exit, and he did just about that in time. The problem that I had with it, like every human being probably does, in just coming to terms with the reality of it as an individual, and that person that you care for is going to be leaving this world, and part of your mind is saying, no, he can still be around for a little while, and we'll get together again. Now, on the other hand, yeah, he was deteriorating, and it was a congestive heart, so more related thing. But he was 87, and he told me, so I had to be over that.
I think that is the challenge, is rationalizing their choice, even if it's not necessarily, you don't agree or don't want them gone, it's their choice. Yeah.
Yeah.
Is there any other questions on mine? Sorry.
Joan,
I just have one last comment. If they don't make it easier for people who know their wishes, then people will just do more of their own thing, and that, you know, that might not be a clean way to do it. I don't know, but it just seems like the more barriers and the harder you make it for people to make their own decision, the messier it gets. And I don't know, it's just so unhealthy and unhappy, promotes all kind of weird things.
Yeah, it has to be an open conversation.
Yeah,
I
yeah,
guess,
for
Joan,
sure.
Are there any barriers that are particularly concerning for you, or I just wanna make sure I'm really understanding the big concern that you have?
I just think if you get to a point and you're, you know, you've lived your life and you feel like you don't have any desire to stay anymore, it should be a little easier, you know? And there's such a, you know, a shroud around suicide, but I think what other options? Maybe change the word or something. Maybe that's something the MAiD people could start to think about. Like, if we don't want to call it MAiD, then here's another option for you. It just should be so much simpler. I don't know. Like, I'm a farm girl, and you know, when it comes to a point where something is not thriving, it's a no-brainer, and I would expect that for myself, you know. Just a thought.
A no-brainer, but at the same time, I do remember the words that were spoken to me. And when somebody doesn't want to be a burden on the healthcare system, or a burden on the limited capacity of the hospital to care, that's hard, because we need to have the supports in place.
Right. Well, for me, it's about independence. Like, I get that part about being a burden. That, to me, I wouldn't like that either. But for me, it's just about being independent. It's like getting in my car and driving off somewhere. It's like, that's how I feel I should be able to live my life.
Well, Joan, I understand what you're saying. We raise horses, and I don't hesitate when a horse is in great distress to euthanize. What I'm concerned about is, I did see a huge step up in the individual choices people had in my palliative practice when MAiD became a legal thing to do.
Right.
And we've seen examples of abuses of it, for taking advantage of people who were burdens to other people, kind of thing. When really the better solution would be to provide a better social and medical health background for them to access.
Right.
And I too.
Right. Yeah, it's tricky. Right.
What if inflation went so high that I couldn't afford to keep my horses? You know, I'd be upset.
Yeah. Yeah, right.
But so there's politics in it, there's healthcare in it, there's individual choice in it. I understand your frustration, but I'm pleased with the MAiD program so far, because it's carefully taking steps towards what you're saying, but making sure that people aren't disadvantaged or use it as an excuse not to provide care, which would make everybody have happier, more fulfilled lives.
Yeah, I think quality of life, and an aspect of quality of life is how entertaining is your life. I think that's a big thing. That's always been a big thing for me. And it'd be nice to see that worked into MAiD. Like, really, what is the quality of life for this person? And then have a history of their wishes. And then it's a simple, you know, choice.
I'm aware of the time that we are past noon. I think we're not going to resolve this particular issue, but please, I will, unless there's anyone who has a final terse comment, I will close the formal meeting and invite the people around the table to stay for coffee and discussion, and thank the people online.
Thank you, that was awesome. Thank you.
Thank you so much for coming.
That was, yeah. Splendid time.
Save me some cookies for later.
Okay, we'll save some cookies. They'll be a little stale.
I'm coming back. Okay, bye.
But
Well, thank you.
thank you. That really was, that was a very